I now call upon Dr. Chandrashekhar Wavikar, who will be talking to us about recent advances in corneal collagen cross-linking.
Good afternoon, everybody, and thank you, Dr. Nitin, for giving me this opportunity. The first speaker, Dr. Ritu, has made my job easier. Now that we have established diagnosis of keratoconus, we need to go ahead with the treatment. That is, the universal treatment is corneal cross-linking. Now there are two types, chemical and physical. We are going to talk only about chemical, and in that also there are three varieties: enzymatic, glycosylation in diabetic patients, and oxidative, and we are going to concentrate on oxidative, that is the C3R. So ultraviolet A light activates the riboflavin molecule, and it interacts with the oxygen to form bonds or the crosslinks between the cornea, thereby improving the strength of the cornea. What is the objective behind it? Primary objective is to improve the corneal strength and thereby halt the progression, whereas secondary objective is improvement in the quality of vision as well as corneal flattening. Now, corneal collagen, there are 2 points to remember: 8 years and 35 years. Entire cornea, the collagen is replenished every 8 years. So that is the time perhaps when we will think of patient requiring second treatment. Second point is that after the age of 35 years, naturally the collagen has become so stiff that patient won't require any cross-linking treatment. There are many protocols are available today, and let us try to make sense of them all. So the traditional protocol is Dresden protocol, where riboflavin is instilled on the cornea for about 30 minutes and then exposed to UV radiation of 3 milliwatts per centimeter square for 30 minutes, thereby giving a total surface dose of 5.4 joules per centimeter square. The limitation is that in this protocol the pachymetry has to be 400 at least, and of course there are disadvantages, and it has to be tackled properly. We were doing well with this protocol, and then we realized that there are some areas where there is scope for improvement. Number one is improving the efficacy, reducing the time required for treatment because it takes about 1 hour, improving the patient comfort, shortening the rehabilitation time, because previously we'll do C3R and we'll do rehabilitation after about 6 months, and that was quite some time. Improvement in quality and quantity of vision, and solution for thin cornea. So let us look at one of these aspects one by one. So for decreasing time, we have accelerated protocols, whereby if you see that the irradiance has increased and the time has reduced, but the total of both is, the multiplication of both is 90. So it is 90 milliwatts per centimeter square. Either you give in 30 minutes at 3 irradiance, or 30 milliwatts for 3. It was shown that till 9 dose of 9 or 10 minutes is safe, but once you start going below that, what happens is that the results are not all that great, and that is because this cross-linking process requires a lot of oxygen, and the moment cross-linking starts, riboflavin attacks oxygen and there is nothing left, and therefore some time has to be given for the oxygen replenishment, and that is why we are come down to now maximum 10 minutes of reduction in time, not beyond that. The same was also established by Theo Seller, that there is a significant decrease in oxygen. Then reducing the patient comfort, increase the patient comfort. So when you do transepithelial, endothelial cells are damaged. Mind you, when we are doing Dresden protocol, after 30 minutes we are ideally supposed to see the patient under slit lamp and see whether the riboflavin has entered the antechamber. That is because we want to protect endothelial cells. Transepithelial, we are trying to protect endothelial cells and increase patient comfort. But epithelium itself is a barrier for penetration of riboflavin and oxygen availability. So that's why the results have not been all that great. They were less effective. Okay. a randomized control trial showed that 23% of the eyes undergoing AP on treatment progress as compared to none with AP off eyes. Then we come to, so what is the solution? That we continue with AP on, but can we do something more? So one is the chemical enhancers. So there are so many molecules available, the important being tris, and what they do is that they loosen the tight interepithelial cellular junctions and therefore improve the penetration of the riboflavin. And indeed they have shown to be somewhat effective, but still long way to go from AP off treatment. Then we go to iontophoresis. Iontophoresis is nothing but electric current applied for the percolation of riboflavin. So first was to percolation of the oxygen, whereas the second thing is for percolation of riboflavin. Again, they were not shown to be all that effective. Then phonophoresis is there, where you are using acoustic cavitation, and oral riboflavin. Both are not very good because oral riboflavin has lot of toxicity. So how are we going to improve oxygen diffusion? In our normal Dresden protocol, there are two things which you can do. One is don't use any dry drops before surgery because they definitely hamper the penetration of riboflavin. Second, during UV irradiation, avoid putting riboflavin because that itself acts as a barrier for the UV light to penetrate. And in AP on condition, what we can do is that we can combine techniques. Number one is pulse ultraviolet A. That means the treatment is given for 8 minutes and 1 second on, 1 second off. So you are giving chance for the cornea, for the oxygen to be available again. Here for the first time we have shown that there is a significant improvement in the results, and the demarcation line also has shown little depth. Then you can have enhanced fluence, pulse, light and iontophoresis. So you are increasing the fluence, you are increasing the oxygen availability, and you are also increasing the riboflavin penetration. Again over here the demarcation line was at 285 microns, which is quite good. Then we can do oxygen supplementation. The demarcation line is at now 320 microns, which is quite good. Now we go to the next topic, is how to improve visual quality. I will come to these slides again. So for that what we do is photorefractive keratectomy or therapeutic keratectomy, PTK or PTRK. With this what we do is essentially we are smoothing the cornea, and both of them have shown that there is a significant increase in uncorrected visual acuity. Keratoconus is a contraindication for LASIK, and then how we are using excimer laser, but over here we are removing hardly 20 to 30 microns of the tissue. Then there is Cretan protocol where therapeutic PTK was done, a transepithelial PTK was done, and with the same result. Again the demarcation lines was shown to be quite low. Then there is some thing called as curve protocol. Unfortunately I did not get much, and neither I have tried this. Then we go to thin cornea. So thin cornea, the simplest thing is using hypoosmolar oxygen riboflavin, so that the cornea swells and we can protect the endothelium. Then you can artificially increase the thickness of the cornea by using contact lens or epithelium island or lenticule, which we get with lenticule based refractive procedures. But the second last most important thing is pachymetry based accelerated CXL. Over here all the factors were taken into consideration and a nomogram was developed. However, this is quite cumbersome. We require a lot of things, and therefore it is not that helpful. So what we come to is just follow Dresden protocol for sub 400, only reduce the time, and this seems to be working quite well. And 90% of the corneas where the thickness is less than 360, they are shown significant improvement. This is the protocol. Everything is same. The only from Dresden, the only thing different is time. And this is the chart which shows on one side you can see the minimal stromal thickness, in between the time, and the last column shows the demarcation line. And it is also available as a calculator on this website. And now perhaps this is the most important slide of the discussion today, is that if you see, these are the demarcation lines which we develop with different types of treatments. So 320 to 350 is the Dresden protocol, and as you decrease or you play with the parameters, the demarcation line keeps on going down, up, and Apion is like the worst. So still we should stick to Dresden protocol only. PRK, LASIK and Smile Extra. I can take one more minute? Yeah, 1 minute. Basically borderline corneas, we can do this extra procedure where the dose given is 2.7 to 3.4 instead of the total 5.4. But PRK itself is a scarring procedure, so it is not proved to be effective. LASIK, you are doing C3R on the lower layers of the cornea, whereas we want to do cross-linking on the upper layers, and therefore the only place where perhaps this is going to stay is Smile Extra. I'll skip this. Thank you very much.